So let me start you with a real case. So this is actually a patient presented to me, but I'm presenting her to you guys now. You will help me to manage this patient. So I have this patient who is 63 years old. She's gravida 4 para 4. She has lost her 18-year-old during the car accident 3 years ago. She was referred to me by the family physician with 1 year history of vaginal bulge. She was saying that she feels something coming out of the vagina. A background history is that she's a known diabetic on treatment. She's on metformin, oral agent for diabetes. She's also chronic hypertension on treatment, well controlled. She had previous total abdominal hysterectomy at the age of 42 because of abnormal uterine bleeding. Obstetric history is that she had 2 seizures and 2 NVDs. Family history is that her mother died at the age of 62 because of breast cancer. I want you guys to keep this case in mind. Just we go through the pelvic organ prolapse discussion briefly, and then you would, at the end of the presentation, help me to treat this patient. I haven't made up the plan yet, so you will be able to make a plan with me after the presentation. So my aim for this presentation, the reason why I just raised my hand when Dr. Magagula called me, it's not necessarily to impress you and show you that how much I know about pelvic organ prolapse. My aim is for you to be able to understand why this pelvic organ prolapse is so important on the patients you are seeing now. It's the same as when during apartheid, when they were fighting for freedom. You know, at that time, no one cares about anything but freedom of the Black people in South Africa. At the moment, I feel like there are some patients who are suffering in silence, who needs to be freed. And the 200 of people who are here are the best instrument to be able to do that. So it will be best to be able to share with each other about this pelvic organ prolapse, purely so that you can able to manage these patients when you see them. Not only manage them, you must also be able to identify those patients who are suffering. Okay, so that is my biggest aim. If anything you can learn out of this or take out of this, for you to be aware of this problem and able to identify and possibly refer to the right people or manage such patients, I would have done my work. So that would be my aim for this presentation. So let's start. When we talk about pelvic organ prolapse, we're talking about a descent or herniation of pelvic organs, which descend or herniate into the vagina or beyond the vagina or outside of the vagina. When we talk about pelvic organs, as you know, we're referring to the bladder, the uterus, and the rectum. So if one of these organ prolapse or goes down or fall down or drop down into the vagina, we would call that as pelvic organ prolapse. The second picture in this first slide, you can see that actually, let's start with the first picture. It's a normal structure of the pelvis where the bladder, uterus, and rectum is in the right place. But the second picture, you see the bladder has dropped down into the vagina and almost protruding outside of the uterus, outside of the vagina. So this would be an anterior prolapse. Okay, so because the pelvis is divided into 3 compartments, the anterior, middle, and posterior. So if the prolapse coming from this area where the bladder is prolapse, we will call it an anterior prolapse. We're no longer using the cystocele. I'm sure the people who have gone to school long time ago, they will say cystocele, rectocele, because most of the times you won't know behind this bulge. Is it a bladder? Is it the small intestine? Is it uterus? Is it rectum? So we would identify the area which bulge according to the compartment where it is. So the bladder will be in the anterior compartment. So in this case, we'll say the patient has an anterior compartment prolapse. We take to the second picture. Second picture, you can see compared to the first picture here, that the uterus is the one this time which has prolapsed. It is actually closing the whole vagina and actually protruding outside. My patients, when they come to me with this kind of a problem, they say, doctor, I see in Changan, they say, and some people will say, it seems like I have a small little penis coming out. And this is because of the uterus prolapsing uh, out of the vagina. So it will be a uterine prolapse in this case. The second picture in this third slide, there is something like a balloon bulging out there. So this is when a patient has a vaginal hysterectomy or had a total abdominal hysterectomy, and then the vault will be the one protruding. The reason why we don't necessarily say it's a vault prolapse or it's a cystocele is because in this area where you see we're saying the vault, there can be small intestine protruding there. So the term we use at this stage will say it's a middle compartment prolapse. So the middle compartment has prolapse. The next picture shows that the posterior part of the compartment has prolapse. And in this case, because we can see in a picture, it's a rectum. So it has actually protruded into the vagina and almost coming out of the vagina. So basically, those are the prolapse which would happen. It's either the bladder, the uterus, the vault, the rectum, and even the intestine. Sometimes even the omentum or the small intestine protruding. So any of those things can be protruding outside. So why do we have to go all out? Why am I trying to be the Nelson Mandela of pelvic organ prolapse? Who cares? Because this problem just happened to the Caucasian people in Western countries, and it doesn't touch our patients, most of our patients whom we are seeing. And if it does, it's just part of growing up. Why are we struggling and we have to spend the whole hour talking about this pelvic organ prolapse? We do have to talk about it because it has a great impact in the patients who are suffering from pelvic organ prolapse. So patients with pelvic organ prolapse are often associated with urinary incontinence. 40% of them will have stress urinary incontinence. 37% will have overactive bladder, meaning that by the time they get to the toilet, the urine is already leaked. They have this agency to want to go and pee, but by the time they get there, urine is already leaked. 50% they actually have fecal incontinence. They can't control their poo-poo, so they soil themselves. And the other issue with patients with pelvic organ prolapse, they will have voiding difficulties. This is because of the kinking of the urethra, because of this bulge coming out. Some of them, they may even have incomplete defecation. You find there's a feces stay in the rectum and they cannot able to push it out because of the rectocele. Sometimes they may have to put the hand in, what we call splinting. And sometimes I have a patient who actually have to put her fingers in to take out the feces because they cannot come out. They also have sexual dysfunction. So if out of you who is listening here, and I can say, pick one of the symptoms you would like to have and you'll be happy with it, no one will raise their hand. Imagine a woman who is now suffering with this problem and suffering alone because us as health workers, we don't ask about it, or we're not exposed about it, and we end up letting patients suffer with all these complications. The other thing is that if a patient has voiding dysfunction and kinking of the urethra, there might be ureteric reflux, where the urine go back into the ureter, go back into the kidneys, and into the kidneys, causing kidney failure. With kidney failure comes with morbidity and mortality. So a poor patient with this pelvic organ prolapse can end up dying because of being neglected with pelvic organ prolapse. So it's important. Okay, so I hope that in your case now you understand why it's important. But you can still say, Dr. Mwawa, yes, it's important, but we hardly see patients with this stuff. You know, yes, it is important for the people in in Western countries, but medical students, when they qualify and be doctors, they will never see these patients. You might be right, because the prevalence of pelvic organ prolapse is very difficult to actually have. You have the exact number of people who are affected. So we can only presume that if we don't have the numbers, possibly there's very few patients suffering. Because even in USA, the only way to get the prevalence, the true prevalence of pelvic organ prolapse, they are counting patients who come forward, who had a procedure. So they are saying in USA, they have plus or minus 200,000 women who goes under inpatient procedure for pelvic organ prolapse every year. So that's a big number, right? So, but you can tell from that statistics that this is just the tip of an iceberg, because they are counting only patients who will come forward and say, I have this problem. And they are not only those who come forward, they are only counting those who had a procedure. What about those who didn't come forward? What about those who didn't have a procedure? So you can see the number of patients with pelvic organ prolapse in USA alone is quite high. Okay, and they've done some multiple studies. If you go and read about prevalence of pelvic organ prolapse, even in our books, which we learn in medical school, they will tell you, no, white patients are the one who has a high risk of pelvic organ prolapse, and patients with family history of pelvic organ prolapse. And in America, they say also the Hispanic patients, they are at high risk of having pelvic organ prolapse. The problem with relying with that is because the people who are being studied in most of those studies are Western people. I'll give you an example of the Women Health Initiative study, the one which they were looking at the hormone replacement therapy. And they were randomizing patients with hormone replacement therapy and those who don't. So they have done a side study on pelvic organ prolapse on those patients who agreed to go in that study. And they found that out of that group of patients, patients who have grand multiparity, who have increased age, who have increased BMI, vaginal birth, vaginal childbirth, and low education level, they were at higher risk of having pelvic organ prolapse. But if you look at the demographics of the patients who were involved in that study, they were almost all of them white. And then they will come out and say, white patients are the ones who are having this problem, right? Because they were able to do that study, that big study in that regard. But our patients in Africa have very few studies being done. Other than the study which is done in Ghana and in Kenya, but in a small quantity of patients where they also check and see patients with early marriage and starting to, who had children early, were also having high risk of pelvic organ prolapse. There are very few. But an interesting thing, I want to stay with this. An interesting thing is that all these risk factors, which are for pelvic organ prolapse, Black patients have it, and they actually may have it more than white patients. That's funny, you know, that we don't see patients coming with pelvic organ prolapse, but with all these studies, they're saying patients with low education. Why low education? Because when you have low education, you're most likely to be working with hard labor, working in the farm. So in America, for those group of patients who were working in the farm and were working hard labor with low education, had more prolapse, but they were white. They had more prolapse than the other white patients. But if you look at how many of our Black women are working in the farm compared to white women in South Africa. If you look at how many black patients who have low socioeconomic status in South Africa compared to white patients, you can see that if you look at how many patients end up delivering at home vaginally without any supervision, or delivering on their way when they are coming from Hakutama to Polokwane. How many patients who have increased BMI who are black compared to white? You can see that all these risk factors are mostly, and you find it in white patients. So it's obvious that there is a group of patients who needs to be liberated. There are those group of patients who need you as a doctor, as a health worker, as a nurse, as an intern, as a medical officer, to be able to identify them and make sure that they are actually going to be to get treatment for that. So let me move on. So the etiology of pelvic organ prolapse is simple. The pelvic organs rest at the pelvic floor and connective tissue and fascia, right? The levator ani muscles, they support these pelvic organs. So they support them just exactly like this round blue thing there, showing resting into these pelvic organs, into this pelvic floor. So pelvic organ comes when this pelvic floor has trauma or has an injury. And this will occur mostly when patients have vaginal delivery, or when they are pregnant, or when they have assisted delivery. So if there's any damage of this supporting structure, and then the pelvic organ will just drop out of that and end up coming out. So that is the most common reason why these patients will have pelvic organ prolapse. So how do they normally present to us? Patients with pelvic organ prolapse, majority of the times, or some of them actually, they are asymptomatic. If you go to a church and examine 100 patients, you'll find that almost 75 out of those 100 patients, they have some form of a prolapse, but it's asymptomatic for them. So most of them would have it, but it's not symptomatic. But those who are symptomatic, they will present with urinary symptoms. So they will have urinary incontinence, stress or urge urinary incontinence, frequency. They will have voiding dysfunction. They can have straining where they have to also push the pelvic organ, the prolapse back so that they can able to void. All right. Other than that, they may have GIT symptoms such as fecal incontinence, chronic constipation, backache or discomfort. They can also complain of sexual dysfunction, where they don't feel or enjoy the process of having sexual intercourse. Because if you remember the second picture where the uterus is actually closing the whole vagina. So when now they're engaging in sexual intercourse, the penis has no space. It just go and chill everywhere there and not have, and the process is not enjoyable because the vagina becomes lax and big for them. So those are the symptoms which a patient will normally present to you. So these symptoms, you must remember them. And for every single patient, when you now starting to ask Dr. Magagule that have you done a pap smear before, please ask them if they have a vaginal bulge. Please ask them about the lower urinary tract symptoms. Please ask them about if the sexual dysfunction. Please ask about the GIT symptoms. Just exactly the way when you ask as a GP doctor when you have a patient in front of you. Because those alone are working as a screening tool. The chances of patient, when the patient tell you that I've got a vaginal bulge, there is 76% chance that you will always going to go and find a pelvic organ prolapse. So the sensitivity of a patient telling you that I have a bulge is much more better and predictive. So Just asking a patient one question, do you feel that there's something protruding down the vagina, or do you feel heaviness? That is one question you can able to get a majority of the patients who have pelvic organ prolapse. So just identifying them, you are able to sort out all this impact we talked about it in the first few slides. So once you have done the history on what patients will be coming to you with, is now to talk about the past medical and surgical history. We know that because of the weakness of this pelvic floor, the weakness can be caused by chronic cough and chronic constipation, anything which increases the intra-abdominal pressure. So you need to ask patients whether they have pulmonary disease, COPD, and asthma. I know I worked in Cape Town, majority of the patients, or most of the patients there, I find that they suffer from COPD, right? So that question should be part of, if let's say you work in Cape Town, should be part of your tracking patients every day. Whether you're in gynae, whether you're in internal medicine, you should be able to ask a question, the patient about that. The other thing is connective tissue disease, because some of the connective tissue disease can result or predispose a patient from having pelvic organ prolapse. And you ask patients about previous pelvic surgery, whether she had pelvic organ prolapse surgery before, or whether she had a hysterectomy, for example, because when we do a hysterectomy, we cut on those supporting ligaments and supporting structures. As a result, these patients are at high risk. So these questions for patients with pelvic organ prolapse are very important to ask. The other important thing on history is the detailed obstetric history, how the patient delivered, was there complications, did they have any tear or episiotomy cut? You know, all those things needs to be asked. How big was their babies, and how did she deliver, instrumental delivery? All those things needs to be asked. And family history, of course. I said initially with the prevalence of pelvic organ prolapse that they're saying in family history of pelvic organ prolapse. Some of these patients, when they come to me, they will say, "Doctor, I don't know why this is happening for me in my whole family. I've never had anyone having this problem." And I tell them, "Ma'am, you haven't had this anyone telling you about this because they were afraid of telling you. You know, people were suffering in silence. You may find that your mother, your sister had the same problem, but they were afraid of talking to you or talking to someone else. Because some of these deep villages, patients with pelvic organ prolapse are called witches. They're saying now this old woman is having something coming down her vagina. She's developing a penis. It means that she has killed boys in her community. Now God is punishing them. You know, so if you have all those stories, would you come out and say, do you have this problem? Because now by coming out, you are telling everyone that you're a witch, right? The other thing is that if old ladies are even afraid to tell you anything just below the belt, they will never tell you whether they're still bleeding or not. This pelvic organ prolapse, which is not painful, they won't tell you. So it's important to have those questions, to remember that when you say family history, and if you don't find it in Black patients, doesn't mean that their parents didn't have this. It just means that it was possibly kept secret. And I was privileged when this patient told me and said previously, and I asked her, did you know about this pelvic organ prolapse? She said, yes. Previously, I was told that they will put a white linen on the floor, and a woman with this pelvic organ prolapse will come and jump on top of that white linen, and it was able to take this thing coming out, going so that it goes back to its position. Whether it ever worked, but she knew about it, at least for this particular patient. The other issue you need to ask about is the issue of occupation. We know with the studies done in Uganda and Kenya that patients who are farm workers, patients who are working with heavy lifting objects, actually are at high risk of having pelvic organ prolapse. So you should ask those questions. And those who are not working as well, our mothers, they go to the mountain to fetch firewood and put it on their heads, and they are carrying the baby at the back. The other hand is carrying the water. The stuff they carry, you cannot even quantify, but it's heavy. So you need to also ask the patient about whether she's engaging in those kind of things. General physical examination, as you know, you have to go and general exam, including the measuring the weight and the height and BMI of the patient, because the increased BMI puts this patient at high risk. So when you see such a patient, you need to be able to do that. And of course, blood pressure and vitals for patients. Most of our patients are elderly patients. They may have already chronic illness. You need to be able to see if the blood pressure is being controlled, because that can influence your treatment and which I will explain more when I get further. So the other thing you should, when you're general examination, you should check the hypermobility or signs that the patient might have connective tissue disease. You see in this picture, this particular person can able to push the finger and touch the hand on, the finger, the forearm on this side. So you can see there's hypermobility of the joints, and that alone can be an indication or a sign that there might be connective tissue disease. And connective tissue disease is high. It's puts patients at high risk. When you do an abdominal examination, check these things such as hernias, because if there's a weakness in one part of the body, there might be also weakness on the other, on the pelvis as well. So if a patient you're examining, you find that she's got an umbilical hernia or she had been repaired before, that will give you an indication that the patient might be at risk because of that. Of course, if patient has multiple surgery, has multiple scars, that is important to be able to check, because in so doing, when you want to now plan to do, when you're now planning to do an operation, that will influence your decision on what type of operation you're going to do. Pelvic exam, I must have warned everyone that for this presentation, if you are less than 18, please, you can close your eyes for now. So just a joke. And unfortunately, my joke, I will not know if it was received well by people laughing. So, but I can see.
We are laughing, Doc. We are laughing.
No, we are indeed. We caught it, Doc. Thank you.
All right. So thank you for reassurance. Some of us will need that reassurance. So, okay, good. Let me continue. So for pelvic organ prolapse, when you examine the pelvis, I always tell my registrars that don't go straight into and just tell me that, oh, the vagina is warm. We know that the vagina is warm. So you have to examine from the outside in. So in patient with pelvic organ prolapse, check if there's vaginal atrophy, because that in postmenopausal patients, you may see vaginal atrophy. Check if there's the rugae, the prominence of the rugae. If in the vagina there is no rugae, it might be an indication of middle defect of the fascia in that area. Or if there is rugae, might be the prolapse might be lateral, or the paravaginal weakness. So it's important to be able to check that and check the cervix, because for a bulky cervix, is something wrong with the cervix, it's a pathology in the cervix, because your management plan will be it will count your decision to what you need to do, whether you take the uterus out or you keep the uterus, will depend on how the cervix looks, whether there's a pathology in the cervix, all those kind of things needs to be checked. Don't just say, I see patients who are sent to me because we have an electronic booking in Limpopo. Anything protruding in the vagina, they will always send it to the urogynecologist. You find a patient, there's a fungating foul-smelling mess coming out of the vagina, as long as it's protruding, it's a urogynec problem. So you have to have a thorough examination of the patient, outside, into the vagina, into the cervix, check the uterus size as well. Is there any adnexal mass? All those needs to be checked. And before you go in, I forgot, you need to also check the perineal body, whether it's the perineal body is long enough or is short, the size of the introitus as well, the size of the whole opening. We do all this by doing a POPQ, or classification of the pelvic organ prolapse. So you can use a POPQ to be able to measure all this quantification of the pelvic organ prolapse, or a simple a measurement by doing a Baden-Walker classification, where you use the hymen as your reference point, that if that prolapse or whatever is protruding is passing the hymen, it is you quantify it to as grade 3. If it passed all the way out, is grade 4. If it's at the hymen, is grade 2. It's above the hymen, is grade 1. So you use that to be able to quantify. And this, you don't need to be a urogynecologist to do that. You, as a general practitioner, before you say you refer the patient as a health worker, any health worker can able to do that, to check all those things and quantify how big the problem is. With pelvic organ prolapse, not much of the investigation, to be honest. Just the urine analysis, because these patients have urinary tract symptoms, the lower urinary tract symptoms. To exclude UTI, you send urine for MCNS, you do urine analysis. Some patients to check for renal function. These patients normally have comorbidities. They have diabetes, high blood, or in severe cases where there's ureteric reflux, there can be renal disease or renal dysfunction. Then you can do a UNE. The other part which you would do is the post-void residual. You can do in your rooms with an ultrasound. You don't need a catheter. With an ultrasound, you put an ultrasound, you ask the patient to go and void. After that, you measure the post-void residual by measuring 3 dimensions on the ultrasound and multiply by 0.75. It will give you the amount. If it's above 100, you know that there is a patient is not voiding completely, and that can be because of multiple things. Can be because of this kinking, or it can be because of neurological problems. So it's important for you to just gauge that and do that pelvic post-void residual. In a patient who is having lower urinary tract symptoms such as hematuria, you may need to send urine for cytology as well to see if it's not cancer. Pap smear, it's a woman, you need to be able to do that pap smear, because if the patient has an abnormal pap smear, your management of a patient with a prolapse with an abnormal pap smear with cancer is different than when the patient does not have. And if there is a problem with a pap smear, then the decision whether to keep the uterus or not, or take out the uterus will be important. The other thing is that these patients with pelvic organ prolapse, because of the bulging coming out of the vagina, they may have PV bleeding. And this PV bleeding can be because of the dryness of the vagina outside, or the cervix outside. Please make sure, don't attribute everything to the fact that it's erosion of the lesion. So if patient has postmenopausal bleeding, please, you must still do an endometrial sampling to exclude cancer as well. More especially because these patients normally would have increased BMI, diabetes, at high risk of endometrial cancer. So treat your patient completely. Once you see that the patient has pelvic organ prolapse, it's not Dr. Moawa, or it's not Dr. So-and-so. You have to make sure that if it's an issue of pap smear, it's done, issues of bleeding is addressed. Radiological examination, a simple pelvic ultrasound is enough to be able to check whether the uterus is normal or not, whether they are adnexal mass or not. MRI, some people still do to check the pelvic muscles to see if there's a trauma into the pelvic muscle or supporting structures. Doesn't change much in management. If a patient has symptomatic pelvic organ prolapse, whether you do an MRI or not, would not make a difference. But an MRI might be necessary in a case where you worried about neurogenic issues. Maybe there's a urinary symptoms which you think is attributed to the neurogenic bladder, or you worried that there's something compression at the nerves at the back. You might need to do that. So those are the things, are additions which most likely the specialist will be able to do, or when you send it to the urogynecologist, they can able to do in those particular patients. Urodynamics, of course, this we would normally do for patients with associated lower urinary tracts, associated urinary incontinence, so that I can see whether I'm going to fix the prolapse and also fix the urinary problem. If there is a stress urinary incontinence and I can see a demonstrable urinary incontinence on UDS, then I can able to say, okay, maybe in this case I can do both surgery for the stress and also for pelvic organ prolapse. But those are specialized studies which in your day-to-day you may not need to do it yourself. You may need to refer the patient. Same thing as cystoscopy. Patient with bladder pain and hematuria is an indication for referral. So that patient needs to be referred so that they can do a cystoscopy to see if there's no cancer, to see if there's no interstitial cystitis, or confirm if there's interstitial cystitis. So with the investigation as a bottom line, basic investigation will do. Urinary CNS, pap smear, if patient is bleeding, endometrial sampling, that's it, and pelvic ultrasound. Once you have this, then you're ready to manage the patient. How do we manage them? We manage those who have bothersome symptoms. If a patient say, if the patient is, because now I go on multiple radio stations, I get patients who come and say the doctor saw something protruding, but it doesn't bother me. I have no problem. I have no sexual problem. So you don't have to do. So the aim of the management, or the aim of treatment, is to alleviate the symptoms. Is for symptoms. If the patient has no symptoms, you don't have to do it. But as a rule of thumb is that once the prolapse passes the hymen, majority of the patient would have symptoms. So, and those symptoms we have already discussed. So there are two options there are multiple options. If a patient has these bothersome symptoms, then you can observe. So you don't have to do anything. You can say, Mom, this will not kill you. It's not cancer. But if you do that, just ask yourself, a patient who's leaking urine, unable to go and sing in church, and this person, or unable to go and share the word of God in church because they have all these symptoms. So observation, people do it by default by saying, Mommy, there's nothing we can do, is part of growing up. That we should never do. A general practitioner or a specialist without an experience in urogynecology, I think that advice of saying is part of growing up, grow up, don't worry, it's not a good answer. So if you're not sure what to do, refer to the people who has an experience and will be able to assist. Other thing is the issue of telling a 67-year-old increased BMI, cardiac problem, and she has chronic hypertension and diabetes, and so, Mommy, you've got a pelvic organ prolapse, go and exercise and lose weight, right? It's a good idea, she needs to lose weight, but going to lose weight and exercising and Kegel exercise for a procedentia, she's going to exercise up until she's in the grave. That procedentia is not going to go away. So please, before you suggest those treatment for patients, please refer to the people who are experienced to be able to assist in such patients. There are viable options. We have a pessary ring. It's a viable option, right? The pessary ring, we put it inside the vagina and support the whole pelvic organs. And it can actually regress the progression of the pelvic organ prolapse. So, you you can offer that treatment. And that treatment, you don't need to refer to a specialist. You don't need to refer to a urogynecologist. You can offer the ring. With a ring, it's a trial of, you try, just like fitting a shoes. When you go to the butter shop, or you go to, what are the Nike to put your shoes in, you're going to try different sizes and see this one fit you. The same thing with the pessary. You're going to try and see which fits, what fits the patient, and it doesn't come out. After putting it, the pessary in, you can ask the patient to walk around in your practice, and if it doesn't fall, and you can also ask her to go and void and go to the bathroom, and if it doesn't fall, it's unlikely that it will fall at home. But if it does fall at home, just tell a patient it's okay, just keep it in, cover in, and bring it at a later stage. And once, if you choose that as a treatment, you need a follow-up. The first 6 weeks, she comes back, you have a look and check if there's no erosion, there's no bleeding, the pessary is still well suited, and patient does not have symptoms. It's important to have that, because this pessary can have its complication of infection, PV discharge, erosion, and for patients who can be lost to follow up, you may actually find that this pessary ring can grow into the vagina and be part of the vagina. At the end of the day, 3 or 4 or 5 years later, she's taken to theater and they found a mess in the vagina they think is cancer, whereas it's a lost ring. So if you choose to give that patient pessary, you must be available to follow that patient up. The first 6 weeks first, and then if she's doing well, you can do it every 6 months. And then if she can able to change the pessary and clean it herself, you can do it every year. But it must be a patient who will be followed up. Okay. So if the pessary is not a viable option for such a patient, for example, if a patient is very young, if you're going to give a 42-year-old a pessary ring, and that pessary ring you're going to give that patient for the next 40 years, you can see changing the pessary every 6 months for 40 years, it wouldn't be the best for such patients. It's mostly better for patients who are much older with medical condition or who are not fit for surgery. Those who are fit for surgery, you need to ask yourself whether they're sexually active or not. Okay, and you need to ask, I say yourself, actually, I take that back. You don't ask yourself, you ask the patient if sexually active or not. Don't assume that a 63-year-old has stopped having sexual intercourse. Don't assume that an 80-year-old has stopped sexual intercourse. And if the patient is 80 years and say, my partner has passed on, and I'm not having sexual intercourse, and then you can offer the colport lysis, which is the closing of the whole vagina. It works very well, but when you do colport lysis, you might need to do a stress urinary incontinence procedure. So that will be an option for a person who is telling you, not who you are suspecting, who is telling you that they are not sexually active and they are not intending to be sexually active, and they are much older. So I will not do a colport lysis for a patient who's less than 60 years of age. And I'm not saying a 61-year-old is not sexually active, but I'm saying when you are even the 60-year-old saying that I'm not sexually active now, I would not advise for that, because she may still get Mr. Right in the next 3 or 4 years or in the next 10 years. So you would want to the patients who are much older, medical condition. Why do we do colport lysis? Is because the procedure is quicker and it's not too invasive. You don't have to go and remove the uterus, and the procedure is much quicker for patients who are very sick, who cannot handle the anesthesia. We can go colport lysis. We can even do it under local anesthesia, right? That's why you choose that. For patients who are sexually active, the approach can either be vaginal or abdominal surgery. So if it's vaginal, it can either be with a mesh or without a mesh. Okay, vaginal at the moment, I don't know many people who are using the mesh, but I know there are companies, and I'm sure some companies are here, who comes and go to the obs and gynae specialist practices and say, I've got this mesh, I want to teach you how to put it. Please do not learn how to do a procedure by being taught by a rep, because rep are not specialists to operate. They might have seen 100 doctors operating. They might have seen the likes of all the gurus in urogyne operating, but they are not surgeons. So the reason why the mesh is not being used now, the vaginal mesh, is because of a lot of litigation. Why? Because the meshes that time, a lot of people with less experience in pelvic organ prolapse surgery were using them because they were told that you do it, that's why you do it this way. I can show you this mesh is very good, and then you have erosion. So at the moment, there are very few people who are using vaginal mesh because of that. But native tissue repair, vaginally, we can do what we call sacrospinous fixation. We can do uterosacral suspension. We can do anterior, posterior colporrhaphy. We can do perineal. All those things can be fixing the pelvic organ prolapse. Abdominally, we can do sacrocolpopexy. With abdominal, we still use the mesh for sacrocolpopexy, which you can do open, laparoscopic, or robotic. Open sacrocolpopexy still possibly be done by the old surgeons who hasn't learned laparoscopy, but it has a lot of comorbidities. The patient will struggle after the operation. And for us, I think it's just a very invasive surgery. It's just like doing endometriosis surgery by open. You know, I don't know if you can. If there are people with skill to do laparoscopic sacrocolpopexy, you would go and open a poor patient at this stage in 2022. So very few people are doing open now. We do it laparoscopically. Robotic, they are doing it started it now in Cape Town. I know in Stellenbosch, they just did one now with growing pains and all that. So, but we are hoping that that becomes a thing which we would do in the future. So we go back. I see the time is not in our side, but let's go back to our case based on what we just talked about. I will need a volunteer here, Dr. Magagule. So now this is our 63-year-old gravida 4 para 4 referred by a family physician with a history of vaginal bulge with that background history. How would you manage this patient? It's an open-ended question. Anyone can switch on their mic if they are allowed to do so, and just give me an advice. You can say anything out of this case. I haven't treated her. I told her that I'm gonna see her on Wednesday after the presentation, so I will be taking advice from you and then manage you according to your advice. Lucky has raised his hand, Dr. Magagule. Is Lucky able to say something?
I will. Yes, Doc. I will give him talking rights. Yes, Lucky, you may unmute your mic if you want to comment on the case. Lucky, you may unmute your mic.
For those who can able to type, you can type.
Yeah, so colleagues, let's engage on the chat. You may type in how you would want to manage the case. Moratwa, you may unmute to comment. Yes, you may talk, Moratwa. You might be having network issues because I see you have unmuted. Let's get more hands.
Yeah.
Yes.
So I understand with the Zoom, it's difficult to have this interaction. But at the end of the day, with this case, you know, going first and say we're going to do this procedure, it's not a good idea. So for a patient like this, you need to cover her fully. I told you the issue of had 18-year-old child died during the car accident. And I remember this because she was so emotional about it, you know? So those are the issues you want to find out when you a patient for pelvic organ prolapse patients is a lifestyle condition. It's not a matter of life and death. So you need to look at those things in totality and saying that the patient is fit for surgery in all respect. You may find that this 16-year-old is healthy, no respiratory problems, no issues, is healthy, but she is emotionally not okay to go for a surgery because she is still grieving a child. So those are the things in your history taking, you need to expand on it. She has a mother who died at the age of 62. She's 63 years old. Mother died of cancer, breast cancer, right? Address those issues of did she have a mammogram with in this issue? The bottom line is, before you can say that I'm going to fix that bulge coming out, look at the patient in totality. I know it sounds simple, and I know we advise our medical students to do this at all time, but when we are now doctors, we concentrate. When I'm a gynecologist, it's like I'm a mechanic with the engine. I work with the engine. If the engine is broken, I fix the engine. So make sure that you address the issues of the patient. For me, there was a patient I had to wait for a whole year before I operate because her diabetes was not controlled. Right? Those diabetic issues, make sure that those things are controlled. While you are doing that, there are ways of treating this patient. You can use a pessary ring in the process while she's getting all this care from the psychologist, while you're doing the mammogram, making sure that there's nothing which can kill the patient or which can threaten the life of the patient. Diabetes is being controlled. Pessary ring is an option, and this option can be done even by general practitioner. Right? You can choose a ring, which is, as long as you're going to follow that patient up, that patient can be treated, and that patient will thank you. Because all these symptoms I told you of urinary incontinence, a pessary ring can able to rectify it. Fecal incontinence, splitting when they are defecating, all this can be treated by the pessary ring. If all this is not a good option for her, then we can go to the surgery. But before we go to the surgery, we have to make sure that that patient is fully worked up. There is no issue of abnormal pap smear or never had a pap smear done because they found a bulge. She needs to go for the procedure or for the operation. So that's how I would be looking at this patient. By the time I go and put a knife, I make sure that all the other areas which needs to be sorted out has been sorted out. If a patient has chronic back pain, you go and operate and put a sacrospinous fixation, she continue having chronic back pain, and you find that maybe there's a nerve impingement, which the orthopedics surgeons could have assisted that before you take the patient to theater. Right. Okay, good. Let me take you back, take it back to Dr. Magagule. Dr. Magagule, back to you. Thank you.
Awesome. Thank you so much, Dr. Maba. I think it was really an excellent presentation. I'm assuming this is the last slide, right? There's no other slide after this, Doc?
Yes, this is the light slide. Okay, let me just send it just for you. It was the question, and I say thank you. So there you go.
Thank you, Doc. Thank you. Thank you. Yeah, I think pelvic organ prolapse, it's such a burdensome condition, you know, for women who are suffering from this condition. You've really taken us through what we should do, you know, practical in the consulting room when these patients come in, the sort of history you need to take, the examination and our discussion of what options are available for these women. So I think it was indeed an excellent talk, and I see a lot of engagement in the Q&A as well as in the chat. So we'll go through those. Dr. Maba, with regards to the prevalence in African countries, is it a matter of us not having enough data that is published about the prevalence? Is it perhaps a genetic issue that we don't see it so much? Or is it the fact that, you know, these women are actually not able to access the services Why does it seem as though we don't really have these women with these conditions? And perhaps it will also help us to also raise awareness as to what the Eurogynae can actually do for these women, because I can bet, as you were saying during the presentation, that we do have these women that suffer from pelvic organ prolapse. But what is your opinion? Why does it seem as though we don't really have it?
Yeah, so the reason why it seems like we don't have it is purely because of the way things are. Because when you are you remember when you're in medical school, they told you that pelvic organ prolapse is not common in Black women. It's written on your Kruger book, right? It's not common, right? And the other thing is that some of the doctors who are trained, they're trained in the centers where they don't have a urogynecologist in their centers. I'll give you an example. In the whole of Mpumalanga, there is no certified urogynecologist. In Limpopo, we just started now, the past 2 years. Let me tell you something. When I arrived in Limpopo, the first few patients I was seeing, I was thinking maybe I'm in a wrong place. I should go back to Cape Town, because the patients I was seeing the nurses, I was seeing the teachers, I was seeing the people working in head office in Department of Health. I was seeing the people who are just around me, who or mostly see their mothers who I, so you could, and then now 2 years later, I'm now seeing a grandmother from Kamashinyamani, you know, because now I go also on a radio station in a weekly basis talking about this. So it's an issue of the fact that when these patients go to a doctor who has never been exposed to urogynecology, they have gone through 7 years. You know, they have read a little bit of pelvic organ prolapse on the book, and the book was also saying that don't worry because Black women do not have it. And then they never saw any pelvic organ prolapse surgery done. So they don't even know if she has this, if by mistake I found it, what do I do? You know, so if you see when you have a bicycle, you see a lot of bicycle elsewhere. For now, because I spoke to 419 people on pelvic organ prolapse, believe me, next month, you're gonna see those patients with pelvic organ prolapse because you're gonna be asking those questions. So to answer your question is that it's very common. It's actually, I believe you, believe in me, it's more common than in white patients. I can tell you that. And it's even higher. They come with a worse pelvic organ prolapse in grade 4, you know, procedentia, the patients I see. Why is it worse? Because all these risk factors are in Black patients. Do you want to tell me, Dr. Magagule, that our skin is so tough because we are Black, it's so tough that it can withstand 7 children delivered normally, which is a high risk of pelvic organ prolapse. It can withstand an episiotomy, which is done, and a patient who have this perineal tear, which is not actually fixed properly in most of the patients. It can withstand this overweight, which most of the studies in South Africa, Black women are much more overweight than white patients. So it's the same thing when we say Black patients in labor ward, they don't feel pain when they're pushing because their skin is so tough. No, it's because we are not offering them, we're not asking them whether they are feeling pain or not. We are not offering them analgesia because we think their skin is too tough. So, Dr. Magagule, this problem is so common. My clinic today in public hospital, I'm booked up until next year, April, and I'm operating every week, right? With patients who are coming from Kabungeni, Kangwashinyamani, deep rural areas who don't know, who don't have a son who is a doctor, a son who is a teacher, because now I have taken upon myself to make sure that I need to tell everyone about this. And thank you for giving me the opportunity. Thank you.
Awesome. Thank you so much, Doc. Perhaps before we go to the Q&A now, thinking about us general gynecologists and the other colleagues that do or perform hysterectomies, I noted in the case that you just presented that that patient actually had a hysterectomy. Now, I'm just wondering, perhaps on behalf of other colleagues, to say, would one consider hysterectomy as a risk factor for pelvic organ prolapse or for vault prolapse? And if so, how best can one prevent, we do a hysterectomy now for a persistent HC, and then I don't want my patient to come 10 years later now with the vault, prolapsing or an enterocele or some form of prolapse. How best can one prevent this at the time of the hysterectomy?
Pelvic organ surgery is a risk of pelvic organ prolapse, including the total abdominal hysterectomy, because we cut those uterosacral ligaments. The theoretical thing you can say you could do, but I don't know if there are studies which have shown that it has a big impact in preventing it. You can just put the uterosacral ligaments together. At least it will keep the vault up at a level of the uterosacral ligaments. So when you do that procedure, you do uterosacral suspension. So you just put the vault, the two uterosacral together when you're doing a total abdominal hysterectomy. And I know most of our ops and gynae specialists, more especially those who are trained long term, they normally do that.
Okay, awesome. Thank you so much, Dr. Maba. So just to maybe take a few questions from the Q&A and perhaps from the chat. I think the first one, you've already mentioned that if a patient is, there's a question by an anonymous attendee. Basically, it's a patient who's been struggling with pelvic organ prolapse for 14 years. And they've been seen by the gynae, and the instruction is that if it doesn't hurt, there's no need for intervention. I think you've already addressed that one. But there's a comment or a question from Dr. Biko in Pretoria. We appreciate your presence, Doc. So he says, working hard usually results in hypertrophy and strengthening of muscles. Could it be that increased risk of POP in these patients is due to something else and not necessarily the tough working conditions? Your comment on that, please, Doc.
Thank you so much. Dr. Biko is my mentor. I'm so excited that he joined us today, and I'm so excited that he commented on that. I saw the question there. Welcome, Dr. Biko. When I was a medical student in University of Pretoria, these are the doctors who look up for, to say, this is a doctor who looks like me. If he can do it, I can do it. So thank you for being an inspiration for us. So yeah, Dr. Biko's question is, it depends on what type of work you will be doing. Dr. Biko, they've done the studies and found that 75% of marathon runners, those who are actually lifting also weight, they have symptoms of stress urinary incontinence or urinary incontinence. Meaning, no matter how hard and how strong you're working those biceps, but if you are exerting a lot of pressure into the pelvic floor, that alone weakens the muscles. So being a heavy lifter, a woman who is a heavy lifter is not helping in your pelvic muscles. What will work will be Kegel exercise, because you are targeting those muscles specifically. But a patient who is lifting, when my mother is lifting a bucket of water on the head, and she's carrying my younger brother at the back, and on the other side, she's carrying Nongayam Kalabza, all this heavy thing is not exercising the pelvic muscle and making them strong. It's just heavy on those pelvic muscles. So in contrary, it doesn't make the muscle stronger. And patients with who lift heavy, who are heavy lifters and they have all these six packs, they are at risk of having pelvic organ prolapse. And that has been shown with multiple studies.
Okay. Thank you so much, Doc, for that. So there's maybe one or two, actually two, that I've seen in the chat as well as in the Q&A regarding the role of physiotherapy. We do have quite a big following of physiotherapists in the platform. So your comment on the role of physio when it comes to pelvic organ prolapse.
Yeah, physiotherapists are my friends. I work with them in my unit, even in private. I work with a group of physiotherapists. It's very important. So with physiotherapists, a targeted exercise on the pelvic muscle. So when we do a pelvic floor muscle exercise or Kegel exercise, so that one helps because you will be exercising and strengthening those particular muscles. In patients with pelvic organ prolapse, though, patients with mild pelvic organ prolapse might get better. And they get better for the urinary symptoms and fecal symptoms, not necessarily the bulge. The bulge, if it's grade 3 and 4, it's very unlikely that with pelvic floor exercise, it will go back. But patients will feel better because they will tell you that I'm no longer leaking urine. They will tell you that I'm now able to defecate without putting my hand in, so they will have those symptoms. So pelvic floor muscle exercise would work way much better for lower urinary tract symptoms in these patients. So we work hand in hand and it works better. And there are studies confirming that.
If I may just
Great.
come in, Dr. Magagula, on this one.
Yes.
You have mentioned the number of treatments or treatment options, mostly surgical, So there's a number of questions around the use of estrogen creams, laser therapy, and so on. Are you able to comment on other options outside of surgery? Thanks.
Yes, good question. So I didn't touch on estrogen, right? The estrogen, a patient who's coming to you with a pelvic organ prolapse, they have atrophy, you're putting a pessary ring, the estrogen is not going to reduce the pelvic, it's not going to make the pelvic organ prolapse disappear. It will just work better for symptoms of the patients. It will work with the erosion of that area. It will work with infection and discharge, and making that pelvic muscle a little bit better by not being dry. Okay, so we know that menopause and low estrogen put you at high risk of pelvic organ prolapse. But treating a patient with a estrogen treatment for prolapse, it's like when you have a headache, Dr. Magagule, and you put a Panadol pill against your head and you rub it against and you think the headache is going to go away, right? So that estrogen is not going to take the pelvic organ prolapse away. It will assist with the atrophy, with the dyspareunia. It will assist with the cracking and bleeding around the area of atrophy, but it is not going to treat your pelvic organ prolapse. It might improve there and there with the symptoms of stress urinary incontinence or urinary incontinence. But remember, if there is a vaginal or pelvic bulge, like a cystocele coming out, and you can't void because there is a kinking of the urethra because of the cystocele, you can give all these peanuts you want with the estrogen. It's not going to relieve the kinking. The kinking will need a pessary or will need surgery. Okay, it doesn't mean that you can't give estrogen, but don't give it and say you are treating the pelvic organ prolapse. You are treating associated symptoms of pelvic organ prolapse. Laser, it works best because it's expensive. If you go and have a laser and you're paying 15,000 Rand, it has to work because your mind, you're saying you have paid so much. That's why many people who are being robbed by a scam, they will never tell you. Please don't misunderstand me. I'm not saying it's a scam. I'm not saying it doesn't work. I'm just saying most of the times it also have the placebo effect because you're paying for it, and you're paying a lot of money for it. And if you're paying a lot of money for it, you will find a way of confirming those symptoms. It will not, laser will not be able to treat a vaginal prolapse. It might assist with incontinence there and there, but it will not take the prolapse away, right? That prolapse, ring pessary, as I go back again, is a viable option which can be treated by a GP, by a medical officer in a public hospital, by a nursing staff who can able to change in a clinic. That can be done. Thank you.
Okay, thanks, Dr. Maba. Maybe the last two, and then I'll ask Dr. Mawela to check if there's any more that we will need to address. Yeah, just a brief comment on the issue of the laser. Very controversial intervention and very, very expensive. I've read some articles with the assertion that, you know, if the tissue is already atrophic, you want to now burn it with laser and hope that it will rejuvenate. So yeah, it sort of doesn't make a lot of sense, but I agree with you, definitely not for pelvic organ prolapse. I think we have a couple of registrar colleagues and as well as specialists. So there's Dorothy Maimani, I'm not sure if they fall into any of the above categories I've just mentioned, but they were hoping that would actually go into detail into how useful or how to actually apply the POPQ pelvic organ prolapse staging system. I remember this was a bit of a challenge, you know, as a registrar, and I'm just wondering, for generalists, you know, is it something that we should really strive to be very good or excellent in? Can we just use the Baden Walker perhaps? And maybe the second question after that would be probably linked to the case you just presented, the patient who you still need to decide what surgery or intervention to offer. There's a question there that asks, what is the best surgical intervention for vault prolapse? Yeah, your comments on that, please, Doc.
Good one, good one. No, thank you. I saw that, Dorothy. I just thought, you know, as I started with the beginning, that do I spend 15 minutes describing POPQ to you and on how you can able to do a POPQ, or I spend the time talking about how do you identify it and how do you do it? To go straight to your question, POPQ is meant specifically so that it is objective. It's not a subjective. So that if I do a study in Limpopo, the doctor in USA can able to interpret what I have done and is standardized, right? So that the inter-observer, inter-observer fault is minimized, right? So in a case where you're a medical officer, you're a general practitioner, a simple Baden Walker classification it should suffice. But in a case where we are doing it so that we can able to do studies out of this, it is best to be able to do that. For registrars, yes, you need to know whether they will ask you in your exam to do a POPQ, never. Okay, if they do, maybe in the next 40 years, but they will not ask you to do a POPQ in your registrar exam. But for subspecialists, which I was part of the examination on last week, yes, if you're doing subspecialist in urogyne, we might be able to ask you. If they ask you as a registrar, I think it's just a little bit unfair. It's a little bit tricky, but once you get it, it's so simple. Right, there is a very nice YouTube video I watched by an Indian gentleman. If you can go to it and just say POPQ, he has actually he's doing the POPQ in front of you. All these measurements. It's once you have done once, it's easy to follow, right? So I did it deliberately of not talking about it just purely because of time, and I didn't think as a generalist you really need to know it in detail. You can use the Baden Walker.
Okay, thank you, Doc. And the other one on the best surgical intervention for vault prolapse
Yes.
after
Yes.
hysterectomy.
So that one is an interesting, you know why? Because where I am in Polokwane, I get more referrals of patients with pelvic organ prolapse or with a vault prolapse more than anyone else from the specialist. But the other referral is from the general practitioners. But these are the only patients I'm getting from the specialists. You know why? Because most of these specialists, what they are actually doing, they are doing a vaginal hysterectomy for a patient with pelvic organ prolapse, but which is not enough, right? Because now when you have a vagina, when you have a uterus, you now have a false sense of hope that if I do a vaginal hysterectomy, I have solved the problem of the patient. You haven't. So a vault prolapse comes because majority of us, when we have a patient who is suffering from pelvic organ prolapse with a uterus, we are going to do a hysterectomy alone. We are going to do a vaginal hysterectomy and we think we have solved the patient's problem. So to answer your question, the best treatment for vault prolapse, it depends on the age again. If it's a younger patient, we will do a laparoscopic sacrocolpopexy, because when you put that with a mesh, the durability and the repeat or recurrent rate is less. It's 5%. If we use a laparoscopic sacrocolpopexy, for that patient to come back again with a recurrence, it's only 5%. Whereas when you do a sacrospinous fixation, the success rate goes to 67%. So it's not that high. It has a higher recurrence rate. So if a younger patient, I will do a laparoscopic sacrocolpopexy. In an older patients with respiratory problems who cannot lie on the transluminal bag for a longer period of time, then I'll do a sacrospinous fixation. Okay, and the patients where I would use the mesh, it's only when that patient has recurrence, right, of pelvic organ prolapse. If another doctor with skill has done the procedure and it recurs again, and then she's not fit enough to go for laparoscopic sacrocolpopexy, and she does not have chronic pelvic pain, she doesn't have diabetes where the mesh can actually erode, in all those things, then I can do a vaginal mesh, but in a very limited patients. In other Western countries, actually the mesh, they have thrown it out of the window, the vaginal mesh, no one is using it. In South Africa, I know some people who are using it, but they use it for specific patients who are for recurrence, like a vault prolapse, which is recurring.